Can everybody hear me? Okay. While he's doing that, I'm James Weihe. I'm a current non-operative pediatric fellow here at Children's Orthopedics of Louisville. I did my medical school training at the University of Kansas Medical Center in Kansas City. So I'm a Jayhawks fan. Sorry, any Kentucky fans. And then I did my pediatric residency training at Wake Forest. So all I heard about while I was there was Dr. Moyer this, Dr. Moyer that. I haven't told him the specifics of what was mentioned, but so today I'm going to talk about kind of the pediatric lower extremity exam, kind of expanding on what's already been discussed, and then ending with some of the more common overuse conditions that you can find in the lower extremity. So just kind of a quick overview of an outline of what we're going to discuss here. So just some of the general basics of really any musculoskeletal exam, but specifically as it pertains to lower extremity. Quick little inserts about alignment and gait, and then moving on to more specifics of each individual joint exam at the hip, knee, and ankle. Again, ending with some of the overuse conditions that we see. So some of the basics, as Dr. Moore had mentioned, it's important to develop a routine for any exam, but whenever you're going to go do a knee exam, if you have it in your head, kind of a specific pattern every time, you're much less likely to forget anything. And it typically makes you more comfortable too while you're examining, because you are almost on autopilot when you're doing it. You also need to make the patient and the family kind of as comfortable as possible. And typically for most kids, unless they're very skittish and want to see what you're doing down at their knee, that's just being supine on the examination table. Another thing too, it's important to have adequate exposure so you can see, feel, move everything that you need to. And so you can imagine if you walk in and you need to examine hip pain or knee pain and they're wearing skinny jeans, that's a little difficult to do. So get them in a gown, get them in shorts so you can do what you need to do. If they already come in and they have a known painful area, leave that for last. If you start there, they're going to be a little angry at you, and it could potentially make it difficult to get a good exam on the other areas. And then finally, compare. Start on the other side. If that helps make them more comfortable, they know what you're going to be doing, and you can know, do they really have a change in their range of motion? Do they really have a muscle atrophy on one side compared to the other? So when they're standing, part of this can actually be done if you happen to catch them walking in the hallway into the room. You're going to be looking as far as what they're doing when they're standing and when they're kind of walking. When they're standing in front of you, looking away from you, look at their shoulder heights. Are they even? And then are their pelvic heights even? As far as their leg alignment, we've already talked about that a little bit, but specifically at their knees, are they in varus or valgus? And this little diagram on the bottom left I thought was kind of helpful to keep in mind what the typical leg alignment would be for the given age. A lot of times they'll start out in genu valgus, varus, and then there may be a little area around 2.5 where they're a little bit more straight, but oftentimes we'll see these kids 3, 4, 5 who are nice and knock-kneed with genu valgum. By the time they're 8, maybe 10 or so, typically that'll kind of straighten out. And then one other thing to check on x-rays if you're wondering about this alignment, other than just doing a drawing of the mechanical axis, like you can see those lines drawn, and seeing where it falls in relation to the knee itself, is to measure the Q angle, which you can see on the bottom right. That's drawing a line from basically where the quadriceps force is from the ASIS down through the midpoint of the patella, and then another line through the patella and the tibial tubercle. And typically it's about 14 degrees in males. Females, it's a little bit higher, usually because their pelvis is a little bit wider. It's good to check their balance and coordination. This is often a little bit more fun to do with the little kids because they like to do things like running, jumping, skipping, duck walks, things like that. When they're walking, as Dr. Moore had mentioned, do they get their heel down? Do they just walk on their toes? Do they have more of an antalgic gait where they're kind of favoring one side and they have a shortened stance phase? Are they keeping their legs stiff? They don't want to, bend their knee at all. Is the patella facing forward? For in-toeing, as was mentioned, sometimes the patella can actually be facing inward, and the foot progression angle that was mentioned as well. And lastly, if they have hip pain or you're worried about it, you can check the Trendelenburg sign where you have them stand with all of their weight on one leg, and then you're looking for abductor weakness. They'll actually tilt their pelvis to the other side due to weakness of the abductors on the leg they're standing on. Rotational alignment is another big thing to look at, and again, best done when they're prone. So you're looking for the internal rotation and external rotation of the hip, as you can see above. the thigh foot angle. When they are prone, you're looking down right in here. You're gonna look at that measurement there to look for any torsion of the tibia, and then you can actually draw kind of a line. I usually use like a little pen just to have a line. I tell the kids I'm not drawing on them because they freak out sometimes. Put a little pen, it's called a heel bisector line, to draw a nice line. They actually kind of did it right in here. And that line should typically intersect kind of between the second and third toes. If it's more lateral kind of out here, then you could envision that the forefoot is adducted. So we're going to start with the hip exam, and this is essential. As a lot of you probably already know, hip pathology can be easily missed at times because it can masquerade as knee pain. And so always check the hips for a lower extremity exam. And you're going to start with range of motion, and this is best done supine. So oftentimes just kind of rolling their leg in a log roll like you're using a rolling pin can kind of check just a little bit of their motion, and then you flex their hip up like they're going to get their knee up to their chest. Then checking internal and external rotation as well as abduction, but when you do the abduction, make sure you're stabilizing the pelvis so they don't kind of cheat and tilt their pelvis on you. Also, you're going to want to palpate in some of the bigger areas where they could have some pain in the hip, such as the greater trochanter, the iliac crest, the ASIS, over some of the hip flexors, and then kind of right in that joint crease. We'll get kids come in and say, oh, I'm snapping my hip dislocates. So there's a couple of reasons why that could be. One of the more common ones would be kind of more actually external to the hip. So it's typically the iliotibial band snapping over the greater trochanter, as you can see on the top. And on that exam, sometimes we'll actually have a kid stand up and just kind of like tilt the pelvis to one side and try to show you that they're popping their hip out of place. And if you're kind of palpating over the greater trochanter when they're flexing the hip, sometimes you can actually kind of feel that snapping over. And then another way that can be kind of helpful to test this is the Ober test, which is down on the bottom right, where you have them lay on their unaffected side, and then you flex their knee to 90 degrees, you abduct the hip, and then you kind of let go of their lower leg. And if they don't really have much adduction, meaning their knee doesn't drop much at all right after you drop it, then the IT band's pretty tight. Another way could be actually internal at the hip would be the iliopsoas tendon going over the femoral head or the iliopectineal eminence. And a way to check for that is this series of pictures down here going across. So you're going to flex the hip, externally rotate it, and then abduct it. So you end up here. And then you're going to extend it, and once you're close to being fully extended, you internally rotate at the end, and you're going to have a popping sensation that you can feel in the groin when you're palpating in here. Last couple of things. I like these ones because the names help you remember what to do for them. So the Fader test involves flexion, adduction, and internal rotation, and that's demonstrated on the top. That would be considered positive if it produces groin pain, and that can be a sign of impingement or labral tear. And then the Faber test, or the figure 4, has flexion, abduction, and external rotation. The figure 4 is because you can see with their legs here, it kind of looks like they're in a 4. And then they're going to have pain or decreased motion compared to the other side. That can be a sign of iliopsoas tightness, SI joint dysfunction, or maybe even a hip joint problem. And then lastly, looking for hip flexion contractures, the Thomas test. This guy on the bottom here, you have them pull, kind of hold their knee, or you can do it, but it's nice if they do it, and flex it on one side, flex their hip on one side. And then if they can't fully extend their hip to neutral on the other side, then they've got a hip flexion contracture there. And going down to the knee, I feel like I've seen a lot of knee complaints so far already, but start with inspection. So if there's any type of trauma, look for bruising, swelling, abrasions, lacerations, any focal areas of swelling, any wounds or scars too. We had a kid who had just had some swelling over his bursa, and then he had this little tiny kind of scar right over it too, and he had a little piece of wood or a rock that kind of got stuck in there and was rolling around in his bursa. So other than the swelling, that other little kind of scar was an indication of what maybe had happened to him. And then again, as Dr. Moore had mentioned, muscle atrophy, specifically in the quadricep, can be kind of a clue for you as what's been going on. So going through it, you're going to I'll get to some of the more prominent places you're going to palpate here in a minute, but as far as the range of motion, again, starting on the other side can be very helpful, but you're going to want them to do their own range of motion, so active range of motion, and then let you move it, remembering that typical is usually about 0 to 130, 135 degrees. You're going to want to make sure their extensor mechanism intact, so if they have an extensor lag where they can't adequately extend their leg to neutral, then you know there's something going on there in the extensor mechanism. And then muscle testing, check their quadriceps, check their hamstrings, and oftentimes that can be done pretty well actually with them sitting and kind of dangling their legs off of the bed and kind of pushing or pulling against you. So I thought this would be kind of helpful, kind of looking at the knee. There's a lot of different things in the knee that can hurt, a lot of things you can palpate and try to find, so kind of go through some of those. Starting at the top, this is basically the extensor mechanism here. You have the quadriceps tendon kind of coming down from up here, and then the patella will be right around in there, and then the inferior portion of the patella. And I'll get to why some of these specific locations are important actually in discussing overuse problems. Patellar tendon in there between the inferior pole of the patella and the tibial tubercle finally down there distally. They could also have pain on either side of the patella in the medial or lateral peripatellar retinaculum. It's a mouthful. And then I also try to think when I'm doing the exam what this corresponds to radiographically. So you can see at the top that's pointing to the distal femur physis, and then the concurrent tibial physis down here too. It's always good to palpate the medial and lateral joint lines as well, and then the condyles. It's important to keep in mind where the other soft tissue structures are on the sides of the knee too. So remember there's the medial and the lateral collateral ligaments. Hamstring kind of comes in posteriorly, and then you have this pes insere and bursa right there. So there's quite a few special tests for the knee, and I want to go through those for you guys to kind of review. So this was actually put out by a family medicine group at University of Wisconsin. But they've got the anterior door test for ACL. So you have them laying down, you flex the knee. It often helps to sit on their foot, and then you're going to try to just pull the proximal tibia anteriorly, and you're looking for a nice firm endpoint right there. And then the opposite is true for the posterior door, looking for the PCL. The one that's actually used a little bit more and can be sometimes a little bit more sensitive and specific though for ACLs is the Lockman test. You don't want to flex this too much, usually about 20 to 30 degrees, and you stabilize their distal femur with one hand, and then you just kind of, again, pull up on their proximal tibia, and you're kind of looking for significant laxity there. Varus and valgus stress tests are going to check for the collateral ligaments. Valgus stress test, as you can see here, you're going to be putting a lot of force right on this MCL. If they have pain, it's probably not actually completely torn, but if they have a lot of gapping or instability, then you're going to need to worry about either a partial or a complete tear of that. And the opposite for the varus stress test for the LCL. You can see the directions are just different. McMurray test is another big one to look for the meniscus. So you're going to start with the knee in deep flexion. Do the medial side, you're going to actually palpate along that posterior and medial joint line. You know, externally rotate the tibia, put it in a little bit of valgus, and then extend as far as you can to neutral. And it's not really positive if they have just a little bit of pain. It's more positive if there's kind of a clicking or catching sensation. And then check the other side by kind of doing the opposite, where you palpate the lateral joint line and internally rotate the tibia and varus. I know at one point, kind of early on in my medical career, I don't think I did this test correctly because of where I was holding. So it's important to make sure that you're able to palpate those joint lines when you're doing it, and actually have your hand up above the knee. Another thing to check for the meniscus is the Apley's compression test. If they truly have a meniscal injury, they're going to get kind of mad at you if you do this, but you're going to have them prone, like this nice skeleton is here, and flex the knee to 90 degrees, and then you just push down on their heel to put a lot of force right on that, right on the femur and the meniscus, and then you just rotate it side to side. A couple more tests to look kind of more at the patella itself is you're going to have the starting position of the patella. You want to check for lateral motion. And if you get far lateral, they're having a lot of significant, what they call apprehension. They're not happy with you doing it, or they're nervous. That's patellar apprehension sign. You push on the patella, and if they've had kind of patellofemoral pain or some damage to the cartilage underneath, then that would be a positive patellofemoral grind test. It's often seen, as Dr. Moyer had mentioned, in the patellofemoral arthralgia kids. And another one is J sign, where if you have them and you have their knee flex and then you want them to extend it, you'll often see that patella doesn't really just go straight up in the groove. It'll actually kind of start and actually make more of a J shape where it comes out lateral as they finish extension. And then kind of making our way down below the knee. Before we get to the ankle though, if they have pain in kind of the lower leg, you want to make sure, is the pain directly anterior, like over the tibia itself, or is it more medial lateral? Could be some more of the lower leg muscles themselves. And you want to make sure you're palpating those muscles too. And as part of this exam, you're actually going to check some of the muscles that work on the ankle, so testing dorsiflexion, plantar flexion, inversion, and eversion of the ankles. And then we're going to get to walking on heels and toes here in a minute. So gait evaluation, as I mentioned, is nice. And a lot of times, if you just have them take 2 or 3 steps in the room, you may not see a whole lot. So if you've got a decent sized hallway, get them out in the hallway. You can see a lot more, and you can even have them run potentially if you need to. Looking at their arch height, if they have nice flexible flat feet at all, and by that I mean you can have them stand on their tiptoes and they form a good arch, or you kind of extend their first toe and they form a nice arch. Again, looking for the alignment of the forefoot. And then heel rise test can be done too, where you have them go up on their toes, and normally the heel should kind of invert when you're standing on your toes. If it doesn't, then there could be an issue with the subtalar joint mobility or the posterior tibial tendon functioning. You're going to want to inspect at the ankle like you have at any other joint before. Again, checking the sensation, the motor. The 2 biggest reflexes would be the patellar reflex and Achilles tendon reflex. And then, again, palpate in a systematic way. There's these ones that I'm going to show you, starting with the known painful area last. And we have a lot of people who come in and say, oh, my 8-year-old just sprained his ankle. Well, he probably has a physeal injury, actually, because the bones are actually weaker at the physis than the tendons and the ligaments at their age. So they might actually have a fracture across the growth plate. But palpation along kind of the medial and lateral side, specifically focusing on where some of those ligaments are. You're going to want to palpate the navicular, the base of the 5th metatarsal, are some common areas for pain. Back on the heel and the calcaneal apophysis, and then of course along the medial and lateral malleolus and those corresponding physes. Another thing to do is kind of squeeze right up along in here, just to check for any syndesmosis injury for what we call high ankle sprain. Again, checking the range of motion, and for checking the subtalar range of motion, if you're worried about a tarsal coalition or anything, you're going to want to kind of lock the mortise a little bit, so you dorsiflex, and then you rock the heel side to side. And as Dr. Moyer had already mentioned with the silver school test, this is just a picture of what you're doing here. You should typically get about 10 degrees of passive dorsiflexion when the knee's extended, and close to 20 with flexion. So when I finished with some of the overuse injuries, Osgood-Schlatter disease, it's already kind of a handful to say, but the formal term is anterior tibial tubercle apophysitis. So we usually just say Osgood-Schlatter. That's the most common overuse injury. It's usually seen in the active preteen girls and then the younger teenage boys. They often will have a painful prominence over their anterior knee right at that tibial tubercle. And it's usually the kids who are doing sports that require a lot of running, jumping. They have pain when they run, jump, climb stairs, or kneeling. I actually had Osgood-Schlatter, and I had to kneel, I think it was 8th grade in church for something for 10 minutes, and I had a lot of things I was saying in my head that probably shouldn't have been said in church. It hurts. And then the x-rays here, I'll show you. Sometimes we'll show things, but one of the more common things you would see would be kind of this. You can have a little bit of fragmentation over here. This is actually kind of after they're a little bit more skeletally mature at the anterior tibial tubercle. So treatment for this, as Dr. Bray had mentioned, with a lot of overuse things, is rest and activity modifications, ice, NSAIDs, some stretching can be helpful. And then a lot of kids will ask about, oh, I saw my friend with this little strap on his knee. Why can't I do that? That's the inferior patellar strap. This is a couple examples of it. The thought is it puts some tension on that patellar tendon, so you kind of take some of that pressure and pulling off of the tubercle. The biggest thing, unfortunately, which they hate to hear for most overuse injuries, is time. Once they're skeletally mature, that pain goes away. And it's the same thing with this next one, Sinding-Larsen-Johansson, SLJ. That's just apophysitis at the inferior pole of the patella. And you can sometimes also see fragmentation or a little small ossicle on the x-rays. Treated the same. So this is one where you can't really see an ossicle pulled off yet, but you can see how that inferior pole of the patella, there's been a little bit of kind of a stretching and pulling on it. And then kind of at the heel, Seaver disease would be apophysitis of the posterior calcaneus. These kids are usually a little bit younger than Osgood-Schlatter and SLJ. It's the early phase of accelerated growth, and they'll have some pain and swelling right at that distal insertion side of the Achilles, usually kind of just with weight bearing. Again, similar treatment. The only thing kind of different is sometimes we'll offer kind of gel heel cups to put in their shoes to help kind of redistribute some of that pressure, but again, it's time. And I put this x-ray up not because there's necessarily a real specific finding on x-rays for Seaver disease. It's more of a clinical diagnosis, but this was a girl who came in with heel pain, and you can see kind of the scalloping of the back of the calcaneus right along kind of where that apophysis is. She was starting to have some calcification in there too. Sometimes you can see fragmentation of that. She didn't, but it was more of a clinical thing. And then lastly, something else to keep in mind too would be osteochondritis dissecans lesions. It's a disrupted blood supply, more common at the knee and then the elbow and the ankle. You can have it in other joints, but a lot less common. These are usually a little bit older kids, kind of middle, late teens. And as you can see here on x-rays, the most common location in the knee is the lateral aspect of the medial femoral condyle right there, and you can see it a little bit on the lateral too. These typically can be treated conservatively with rest, sometimes even non-weight bearing. But if the fragment is unstable, or particularly if it's floated off into the joint, sometimes they'll actually need to surgically remove it and then actually do some drill holes into the bone to stimulate some blood supply and eventual healing there. So I wanted to finish up just some of the quick points for you guys. Can't stress enough, develop a routine when you're doing an exam to make sure you kind of remember to go through everything you need to, compare the other side, and then do it again. Observation can give you a big portion of your exam before you've even touched the patient actually for some of these things. Always have a low threshold for evaluating hip pathology if you don't want to miss that. And then, again, the best treatment for overuse conditions is rest or just activity modifications. And that's all I got.